Okay, chapter 9 talks about joints or articulations. I'm going to provide an overview of that topic. There is a great level of detail, as you will clearly see when you start reading and getting into the slides. I'm just going to hit some highlights. We're going to do some activities that will talk in detail about some of the points that I gloss over, and then try and focus on the four specials, shoulder, hip, knee, and elbow is my focus. But we've got a few things to talk about before that. So an articulation is where two bones come into contact and where movement is going to occur. And so there will be two things we're always going to consider when we talk about a joint. It's going to be that joint strength and its mobility. And you'll see that those two things are always going to be kind of against each other. There are two ways to classify a joint. One is anatomically, so based on its structure, and the second is by its function or its range of motion. So first of all, there are a few categories of structural classification. A fibrous, a cartilaginous, a bony, and then a synovial joint. So fibrous and cartilaginous joints will be less movable, and we will be focusing on the synovial joints as being our main focus of our next couple of weeks. The functional classifications relate to their mobility. So an immovable joint is referred to as a synarthrosis. So that would be like the sutures in our skull. They are articulations between bones, but they don't move and they have no movement. The second category is amphiarthrosis or an amphiarthrotic. That's a slightly movable joint. So these tend to be cartilaginous joints like our pubic symphysis or our intervertebral discs between our vertebrae in our backs. Lastly, you have diarthroses or diarthrotic joints, and those are the freely movable. So when you think of a joint, like your knee, your elbow, your neck, your ankle, your digits, your knuckles, those would be diarthrotic joints, and they tend to be the synovial joints that we are going to talk about. A synovial joint has a lot of characteristics. It has a lot of key features that are important to it. I'm going to talk about a few of those, look at some labeling, some images, and then get into some of its supportive structures. So a synovial joint, you're going to typically find at the end of any type of long bone. It is going to be surrounded by what's called a joint capsule. And that's going to have what's called the synovial membrane. This is what makes it synovial, in that it's going to have this membrane and it's going to secrete a synovial fluid. And that synovial fluid is going to provide essentially lubrication for the joint and provide that mobility. It's also going to have articular cartilage. And we saw that when we did our long bone dissection, that white, shiny cartilage that was on the end of the bone. Here's a very generic picture of a synovial joint. So let's take a look at some of those features I mentioned. So here's that joint capsule here, all right, that we're looking at in this space. We have the fibrous joint capsule that's located there. You can see the ligament that is going to connect the two bones on either side. You can see that there is space in between the two bones, and that's where the lining is going to be the synovial membrane, and then the synovial fluid is going to fill up within that space. And then you can see the two pieces of articular cartilage here, protecting the two bones that should they come into contact, they do have that buffer. And then you can see here from a sagittal section looking in from a lateral or medial view, medial, since I'm looking at the tibia of our knee joint, all right? You can read in a little bit more detail about those structures that I mentioned, those main features, but you do also have accessory structures, things like other types of cartilages, pads of fat that are located within the joint, obviously ligament tendons, and then these things called bursae, all right? So some of those cartilages are sometimes referred to as menisci or a meniscus. You've probably heard of those. Some people tend to tear them or rupture them, especially in their knee. That's a piece of fibrocartilage, and it's basically like a seat cushion that goes on those condylar surfaces of a lot of our long bones. You also have adipose tissue or fat pads that are going to be surrounding that synovial membrane deep to it, and that will provide, again, another buffer for that joint. Ligaments are very important in stabilizing joints because they are going to provide tension for the bones that are articulating, and they are going to provide strength at that joint. When you have those sprains or strains, right, something has happened to that ligament, usually some type of torn fiber in that ligament, and that has weakened the stabilizing structure of the joint. A tendon is a part of a muscle that extends to attach to a bone. So this is where we get into the muscular piece. And that's what we'll continue on in next semester. And then lastly, you have these bursa or bursae sacs. And basically these are small little, almost balloons, like a water balloon, very tiny ones that are pockets filled with synovial fluid. And basically it allows for bones to be able to move over one another without, again, generating a lot of that heat and friction and damage when that joint is involved in movement. Do make sure you take a look. This is section 9.2 in your text to read about these 4 factors that stabilize joints. It talks about those in a little bit greater detail, and you'll be doing a little activity that'll talk about that. But I do recommend taking a look at what your fibers, your surfaces, your shapes, those accessory structures, as well as our tendons, essentially helping to stabilize each and every one of our synovial joints. Another activity you're going to be doing is a synovial joint movement activity. So you're going to be looking at different types of motion. So I just want to talk about some of the general characteristics, and then you will be exploring flexion, extension, abduction, etc. Whenever we talk about a movement at a joint, we are always looking at what plane it is on. So are we on one plane, that's uni or monoaxial? Are you biaxial? So can you move in 2 different directions, right? Can I bend and then can I move side to side? And then triaxial, meaning I can move in 3 directions, right? So I can flex and extend, or I can abduct, I can flex and extend, and I can also be involved in some rotational movement. So planes of motion is always something to keep in mind when categorizing different types of synovial joint movements. These are the main categories of those movements: a gliding movement, which is really just 2 bones slightly sliding over one another, like we see with our carpals. Angular movements, which is what I just mentioned. Circumduction, which is kind of like a combination of 4 of those types of movement. Rotational movements, so like what we would see with our neck. We have medial and lateral rotation. You also have it with your shoulders and your hips. And then there's various types of special movements, and I'll kind of jump through each of those, okay? Our angular movements here, flexion, extension, and hyperextension, I would say would probably be our most familiar. Something I would recommend that you do as you go through each of these movements, as you read through section 9.3, is to understand what it means to flex. When I flex at a joint, that means that I am decreasing the angle between the 2 articulating bones. So if I'm talking about my elbow and I'm saying I'm flexing at my elbow, then the 2 bones that are connected there, my ulna, all right, my ulna and my humerus, I am decreasing the angle between those 2 bones. I'm bringing them closer together. And so you can see my angle here has decreased. That's how I know I have performed flexion. Extension is its opposite, in that I'm going to increase the angle between my 2 articulating bones. Hyperextension would mean I'm going past anatomical position. So I'm moving past that kind of 180-degree point and going beyond. All right. And sometimes when we hyperextend things, that's where we can do some damage to those accessory structures on our joints. All right. And here's some images that show you that there's various body parts that do these movements. That's going to be part of your activity. The next pair are called ab and adduction. Abduction means to move a body part away during a joint movement, and adduction means to move that body part of those bones closer to our trunk or main line of our body. Again, images to show how that works. Circumduction is a combination of all 4 of those movements I just mentioned: flexion, extension, ab, and adduction. And we tend to see that if I were to put my arm out and move it around as if I was kind of circling a cone. I'm technically doing all 4 of those types of movement when I perform circumduction. Right, and she's showing you that on the big picture there. The next group of movements are called rotational, and there are 2 ways in which you can rotate something. You can rotate something medially, so towards the midline, and you can rotate something laterally, so away from the midline of the body. And again, you've got those images to help you with that. You also have a secondary rotational movement, and that occurs at that proximal radial ulnar joint. I talked about that crisscross when we looked at our bones there. We have that pronation and supination. All right, so we can rotate so that we can turn our palms downward. That's called pronation. All right, pro basketball players need to be able to do that to dribble the ball. And then we have supination, and that is where we are in anatomical position and our palms are facing anteriorly. So they are supinated there. All right, so you've got soup. Holding that soup in your hands is what you would be doing if you were performing that supination. Pronation, I would be turning my palms downward. Again, you can see some images of that. And then we have a whole slew of specials, and they come in pairs. So the first set here, all 4 of these involve your feet. So you have an inversion, eversion. This is moving the sole of your foot either medially or laterally. Typically, we talk about these movements when you have ankle sprains or strains. Dorsiflexion and plantar flexion. Dorsiflexion is when you lift up your toes. So you are bringing the back of your foot up. And then plantar flexion is when you are pointing your toes down. So like a ballerina would do. We have opposition. So that's when the cool things that our thumb can do, and moving our thumb kind of all the way across our palm. And then we can reposition it by bringing it back. Then we have protraction and retraction. That is a pulling forward and a pulling back. So usually we talk about that with our jaw. Depression and elevation. Usually we talk about it with our shoulders and our scapula, right? I can elevate, all right, my shoulders and I can depress them. I can also do that with my jaw. I can depress it and I can elevate it by bringing it up. And then that lateral flexion of the vertebral column. We can also do that as well, a little jazzercise if we wanted to. So you'll be doing that in your activity. Next, with synovial joints, we also classify within the synovial joint category into these 6 structural categories, depending on how they are made. So we have plane, hinge, condylar, saddle, pivot, and ball and socket. And something that you want to be able to recognize for each is what planes of motion can we work on? Are we non-axial? Are we monaxial, biaxial, triaxial? And then what are some examples of each of those? So again, please make sure that you take a look in section 9.3, look at each one of these types of joints, plane, hinge, condylar, saddle, ball and socket, and pivot, and identify that information, right? There are some nice little images that go in and that will give you an example. So this graph or diagram, very helpful for each of the types of joints. It tells you what movements are possible and it gives you examples of each of those. And we'll talk about that when we are doing our pear deck. So plane joints provide that gliding motion. This is what you're going to see in your intercarpals. So in between, in your intercarpals, so in between your bones of the wrist. A hinge joint's going to function like your elbow does, your ankle does, these 2 joints on your phalanges, as well as your knee, even though your knee is technically referred to as a modified hinge. Condylar joints are shaped in this kind of concave convex situation, allowing for biaxial movement. Your wrist can do this, so you can flex and extend, but you can also wave high and by. Same thing with your metacarpal phalangeal joint, in other words, your knuckles. So I can flex and extend there, but I can also go, that's not enough studying with that finger as well. The next 3, your saddle joint is the joint of your first carpometacarpal, so your thumb, and that allows for that oppositional movement, all right, opposable thumbs, a unique characteristic to humans. Next, you have the pivot joint. That's a monaxial rotational joint in that our neck, our atlanto-occipital axial joint there, where we can shake our heads no, as well as that proximal radial ulnar, so allowing us to do that pronation, supination. And then lastly, you have the ball and socket, which comprise our shoulder and our hip. That is where we get, as you can see, all the rotation, all the circumduction, all the angular movements. That's our triaxial joint. Obviously, the shoulder a little bit more freely movable than our hip. Basically, the remainder of the slides go into detail about each of the 4 specials, as I like to refer to them, elbow, knee, shoulder, and hip. We will take some time and I will walk through these together with you. In class, I just want to, and talk about them. I just want to take a look at a couple of the images that are associated with these joints. So you can get a couple of the ligaments into your mind before we talk about them. The annular ligament is very important. That's that strap that's going to go around the radial head to allow for that pronation supination, as well as these collateral ligaments. You're going to have some radial ones, and then you're going to have some ulnar collateral. Collateral just means on the sides, and it provides that stability. So you're going to see that both on the elbow and then especially on the knee to basically secure that joint and allow for that hinge-like movement between the bones involved, which in this case, the ulna and the humerus, with the radius being peripherally involved as well. The knee is got a lot going on with it. I don't know a nicer way to say that for the knee. Here are all of the ligaments that are involved in supporting the knee. So that's why we call it a modified hinge, because it doesn't have any bony structures that interlock the femur and the tibia, as we've learned. It basically just is those bones on those four condylar surfaces, and then all these ligaments holding it together. So we have that patellar ligament on the anterior surface. You have two popliteal ligaments, which are posteriorly located. You have two cruciate ligaments, which I'm sure you're all familiar with, anterior and posterior, or ACL and PCL. And then you have two collateral ligaments. You have a tibial or a medial collateral ligament, and then you have a fibular collateral or lateral collateral ligament. So here's our knee. And this is our anterior view. There's that patellar ligament stabilizing. We also have the quadriceps femoris, which for knee replacement patients is one of the most important muscle groups that need our quads that need to get rehabbed to give strength to that knee replacement. And then we have those collaterals. So we have that medial or tibial collateral here, and then we have the lateral collateral or the fibular collateral on the side with the fibula. If we take a look inside the joint capsule, if you will, we can see our PCL and our ACL. They are named anterior and posterior based on where they attach to the tibia. So the ACL attaches on the anterior portion of the tibia, and then the PCL attaches to the posterior portion of the tibia. All right. You can see the two menisci here. So those two pieces of cartilage that are sitting directly on the medial and lateral condyles, of the tibia. And you can also see the collateral ligaments as well, located on either side of the knee. All right. Here's another posterior view, looking at some of the musculature and mainly the ligaments that are found there. Here's those two popliteal ones that are located to stabilize the posterior portion of the knee. So bottom line is the knee's got a lot going on. It has a numerous amount of ligaments to hold it together because, again, the bones don't fit together like the ulna and the humerus do. So we will take a closer look at those knees, especially those of you familiar with any type of knee injury. The last two specials are the shoulder and the hip, and I've already talked a wee bit about them and differences between their anatomical structures that form the joint and what they're capable of doing. So our shoulder joint, as I've mentioned several times, has the greatest range of motion, and that's because of the lack of stability in the joint anatomy itself. But it's also the most frequently dislocated. Obviously, that has a lot to do with its structural capacity. There are numerous, again, assistive structures here to create the shoulder itself. That involves something called a labrum, so pieces of fibrocartilage that are essentially going to create a socket in the glenoid cavity that doesn't exist. You are going to have numerous ligaments. You can see a list of them here that are going to be involved in making sure that shoulder stays intact. And then you're going to have numerous muscles. I'm sure we're familiar with rotator cuff muscles. We will look at those in detail in second semester. You have several bursae, so these little bursa sacs that are located, those synovial fluid tiny water balloons that allow for, again, all of that movement that is going to be generated in the shoulder. So hopefully, just slipping back here, you can see that there are numerous structures that provide for the stability of the shoulder. And we can see just a few of those ligaments here, a lot of those coracos and acromioclavicular ligaments that are attaching acromion to coracoid process, clavicle to the scapula, and so on. You can also see the labrum located here, again, creating a deeper socket within the glenoid cavity, as well as numerous tendons. Here's a few in green of those bursae. those little water balloon sacs. Just a lot happening with the shoulder. So again, a lot of creation of the joint through essentially the ropes and the wires, the ligaments and the tendons and the bursa within the shoulder. Last but not least is our hip, strong ball and socket joint. You do still have a wide range of motion here, but much less so than we saw in the shoulder. You also have a labrum here. Again, that piece of fibrocartilage is just going to kind of buffer within the acetabulum. You have numerous ligaments again within the hip itself. So there's that acetabulum. Let's get to those ligaments. So here you can see the femur. Majority of the anterior surface of this hip are covered by two main ligaments here, our pubofemoral ligament, as well as the iliofemoral ligament here. And that's going to wrap around towards the posterior side. Here you can see it continuing. And then you have the ischiofemoral. So again, at that attachment point of whether we are on the ilium, ischium, or pubis of the pelvic bone, right? Your project for this unit is going to consist of you taking a look at a joint injury for one of those many ligaments or joint structures that we just mentioned, or it's going to have you take a look at some type of disorder, something like arthritis or sprains and strains, gout, numerous different types of degenerations and disorders that can happen to your joints within the body. And basically what happens during these degenerative joint disorders is that you essentially decrease the amount of synovial fluid. And that's the whole purpose of a synovial joint, is to have that fluid to be mobile. And when you have a condition that prevents that from happening, it makes the joint very creaky, kind of like the Tin Man in The Wizard of Oz. And so you need to have that lubrication in order to provide for that movement. So very quick overview of joints. We will go into some more detail of a few of these things in our overview couple of weeks.